And maybe before I start, let me introduce myself, Jeremy Lim, and I'm a partner in the healthcare practice based here in Singapore for my company, Wyman. And please permit me to start with a small apology. Immediately, it was pointed out to us that really 5 men on a panel is not the way to go. So, to all the women in the panel, we encourage comments, questions. Please do so. In fact, the five of us waited quite a long time on the third floor to get into the lift to come up here. We were afraid you guys would start without us because I see so many esteemed experts and real gurus in the health tech, in the health innovation space. What we have curated today is a very multidisciplinary panel. Please forgive some of our past as management consultants. Please forgive us for that. We have got 3 medical doctors also, and we've got investors and also entrepreneurs and doctor entrepreneurs. So maybe could I start the ball rolling by asking each of you to just introduce yourselves very quickly and say a little about yourself and the organization, and maybe Prasanth, could you specifically share, because I think that B Capital, it is well known, but in health, perhaps you're not that well known. Could you share some thoughts about your investment philosophy and really what it's about? And maybe shall we start with Vinsha?
So I'm Boonsha Goh, and I am a professor at the National University of Singapore, and I'm a trained medical oncologist, but I also do clinical pharmacology and develop drugs, especially in the field of oncology. So I also direct the investigational medicine unit. So I run several teams of clinical trial teams and work a lot with pharmaceutical companies, as well as academic scientists to develop drugs for treatment of cancer. But today I have something which we are going to share for the others.
Russell? Thank you. Good morning. My name's Russell Gruen. I'm a professor of surgery at Singapore's Lee Kong Chian School of Medicine, a new medical school, and I'm executive director of NTU's Institute for Health Technologies, where I bring together the engineering power of NTU with the health services and clinical environment. My field is trauma surgery and general surgery, but I've also been one of the growing numbers of clinicians interested not just in sort of clinical practice, but also blending that with an interest in encouraging access to surgery and access to high quality clinical care for the global community that needs it.
Thank you. Please.
Thanks, Jeremy. Kabir Narang, a partner with B Capital based out of Singapore. My background over the last 15 years has been a combination of consulting, so with the Boston Consulting Group, then Warburg Pincus and Fidelity. I've been looking at investing in technology, and which also includes healthcare over that time period. So some of the more relevant ones include one of the leading tertiary hospital chains in Asia. We invest in a pharma company that we help list, and so looked at it both from a tech angle here as well as a more traditional healthcare aspect. At B Capital, very focused on Series B, Series C investments. Big belief that technology is transforming several industries. There are 4 in particular that we've looked at: healthcare, financial services, consumer, and transportation. We believe it's happening globally, so we have offices across Singapore, San Francisco, and Los Angeles. So excited to be here.
Thank you, Kabir.
Prashant Tandon. I'm a digital health entrepreneur. I run a company called 1MG out of India. It's India's largest digital health app. We have around 25 million monthly visits on our platform. Mostly it's healthcare information at the core, and then we run an e-pharmacy, e-diagnostics, e-consultation, telemedicine services for consumers in India. Before this, I started another, not a digital health, but a healthcare e-commerce company called HealthCart back in India. Prior to that, I used to be a management consulting with McKinsey and Company out of San Francisco, largely focused on healthcare. So that's my background. Last 7 years, I've been in the healthcare technology space, pretty much in India.
Well, thank you, gentlemen. And today's panel really focuses on the formidable challenges that Asia faces in both cost quality in the 3 arms of cost, quality, and access to healthcare. It is clear that the needs are formidable, are tremendous, but the opportunities to make a really incredible impact are also great. But the difficulty then comes in more of the same will doom us to failure. It's so clear, like there's this, like for example, there's this oft-quoted statistic that I suspect is wrong, but what the Filipinos tell me is that 4 in 10 Filipinos die without ever having seen a doctor in their lives. And that's a shocking statistic. How then, if we perpetuate the current model, the doctor, the individual doctor, the individual patient, how then can we provide for the massive unmet needs? And can technology help us to overcome some of these issues? And maybe can I invite Russell to perhaps frame the issues before I would ask some slightly more targeted questions. Russell, over to you.
Great, thank you. Well, I'll give you a particular perspective from the world of surgery, because in 2014, Jim Kim, the president of the World Bank, said that surgery is an indivisible, indispensable part of healthcare. And what he was doing by saying that was saying that the world has changed, that no longer are the greatest causes of lives lost, of disability and lost productivity, infectious diseases and maternal and child health problems, but that even in poor countries, the ageing populations and industrialisation has led to a veritable epidemic of chronic diseases and of injuries. And in my field, trauma, there are more lives lost worldwide from road traffic fatalities than there are from malaria, HIV and TB combined. What Jim Kim was also saying was that our traditional approaches to solving these problems are outdated. Unlike community-based healthcare with drugs, vaccines and sanitation that were the hallmarks of infectious disease challenges, surgery requires hospitals. It requires operating theatres, it requires trained staff, it requires high-quality equipment and consumables. We, as a global surgical community, have asked the question, how do we start to fix these problems and what is the scale of these problems? I'll show you a first slide. Can I just pull up my first slide, please? So I took this photo in Myanmar on the weekend. This was an emergency caesarean section. A good result, a safe and healthy mother and a safe and healthy baby at the end of this operation. It was done by a skilled surgeon. But I think what we don't see in this photo is actually the facility in which it was being done. Next slide, thanks. And this is a photo taken after that operation of that operating theatre that shows, I think in better detail, the state of the world's surgical facilities. The sticky tape holding together the windows, the bare cables lying around the walls, the mould on the operating theatre walls that were built more than 50 years ago and not renovated since. Now, Myanmar has 350 of these frontline hospitals which deliver surgical care, and they are almost all in the same condition and the same state. Next slide, thanks. There are 5 billion people, we estimate, that can't get access to safe surgery and anaesthesia. That's almost 2/3 of the people on the planet. It's not a straightforward problem to solve. It needs workforce, it needs investment, it needs strengthening of healthcare systems, and it needs safe operating theatres, good equipment and good supply chains. Fortunately, there has been a lot of interest in the last 5 years alone in this, and the World Health Assembly passed a resolution. The Lancet devoted a whole issue of its journal to a description of the problem, setting goals by 2030 and a roadmap of how to get there, and the World Bank has been a major stakeholder. I think I might pause there because I think we've defined the problem in this field, and we'll come back to what are some potential solutions later.
And maybe can I ask Bunsha to, because we have framed very quickly the extent of the surgical challenge, but even in the medical challenges, access to medicines and even payment to even payments for really medicines. I think that Novartis announced cutting-edge therapies last week. Maybe Bunsha can share a little. It also announced it was intending to price it at 475,000 US dollars. So even if these technologies exist, if they can't reach people either because of physical barriers or because of really financial barriers, we're not really solving these very fundamental challenges. Maybe Bunsha, could you share a little about that?
So I think I'm going to talk about, apart from Russell has talked about surgery, but I'm going to talk about cancer. So basically, Asia is growing in numbers. A lot of the population is shifting towards Asia. And in Asia, there's a growing increase in the middle income population. And these people will need cancer care. And these cancer care will therefore, you have a need there. And yet, they're not accessing it. A lot of them are not being able to access this care because of the cost. And these cost models, which were developed in the West, are not in play in Asia at all. Because in Asia, a lot of cancer patients still pay out-of-pocket expenditure. They have to pay out of their bank accounts. And they don't have third-party payers. They don't have insurance. A lot of the countries do not have countrywide governmental subsidies or so on. And so many, if you price a drug, for example, in the as what Jeremy said, in the 400,000 range, it is quite out of reach of a lot of patients in Asia. So, and that is a real issue. In the past 10 years, the understanding of molecular medicine has allowed a huge slew of small molecules, monoclonal antibodies, which entered the market and have efficacy in treating cancer. And we know, because the SEER data shows us that the projected mortality from cancer has dropped significantly, both in males as well as in females. And this is largely because of better cancer care. However, it's the access that is the problem. In the year 2001, average family paying for cancer drugs will pay a month about 3,325 US dollars, but currently in 2014 it's about $13,250 dollars, and salaries haven't increased that significantly in this period of time. So you can see the issue. There's going to be a runaway bandwagon here, actually. So this is the issue that we're trying to tackle. How do we get access of effective cancer treatments to these people who need them in Asia? And the population is growing older, and it's going to be a chronic problem. So that's the issue.
But it's so clear also that if we just throw more resources into this, we will run into difficulties. Where are the game changers? And I was struck that this morning Piyush shared about how banks are shrinking, he needs fewer frontline staff. But also earlier this year, Singapore's Ministry of Health said that the health sector is short of 32,000 healthcare professionals. He didn't mention how we're going to pay for them. That's a different story. Right? But maybe, Kabir, could you share where are the game changers and how can technology really enable this quantum leap?
Yeah, I'd almost go a step further and say technology has to be one of the most important solutions to kind of the healthcare problems facing the world, right? And I'll tell you why. I think on one hand, you already have infrastructure which is not meeting with the current demand, right? If you look at number of hospital beds per 1,000 people, number of doctors, number of nurses, it's already substantially lower, right? Keep the US aside, if you look at markets like the UK, if you look at Asia, anywhere in Asia, you've got countries which are 20% to 50% of what WHO will say is standard. Throwing more resources, it's not happened in the last 5 years, 10 years, 15 years. I don't think it's going to happen as a solution going forward. The only way to really solve it is technology, right? And so what does that mean? It means how does technology play a role across primary care, secondary care, tertiary care? How does technology play a way of improving efficiency of the system? Very critical thing. At B Capital, we've spent some time in that space. So, for example, one of the investments is a company called Bright MD, which is really kind of helping triage how does primary care work more effectively. So, 250 million primary care visits in the US alone every year. How do you kind of triage so you're going to get a sense of what's urgent versus not? So it helps the efficiency of the system, and that's kind of a big pain point. I think similarly, and I'm sure Prashant will talk more about it, From the consumer standpoint, I think consumers are getting much more demanding. I think the day where people will say, I don't know exactly what happens and I need to go for a diagnostic after a year or 2 years, I think those days are kind of slowly, going back. And people want to know immediately, what am I doing, whether it's a Fitbit, whether it's other modes of understanding. I think that's going to be an interesting thing where consumers are also going to become more demanding, and you need technology to kind of provide that solution.
Maybe, Prashant, can you, we've spoken about all these game-changing innovations and where the potential, but you having been down in the trenches, facing regulators who say this can't be done, this doesn't exist, and can you share some of the experience and how, in your view, has this changed over the years?
So I think we are pretty much at the beginning of an inflection point is what I feel. Technology has massively disrupted a lot of sectors. We've all seen that, I'm sure, Kabir, the sectors you guys invest in, transportation, finance, even consumer side, entertainment. A lot of these sectors are fundamentally being disrupted by technology, and healthcare has so far not been touched, or we're just seeing the beginning of that happen. Now, why has it been like that? Because in healthcare, we have a very, very strong and legacy regulator across the board. And for a lot of innovation, the perfect ends up becoming the enemy of the good. You try to create a Mercedes model for everyone, and it's not going to work. People who right now have nothing will not be able to afford that kind or that level of healthcare. And technology has to kind of break down all those barriers. Now, the other interesting issue that has been till now is people who work at cutting edge of technology, digital technology is what I come from, do not have the feel for the needs of healthcare. They understand entertainment, gaming, dating, finance. They understand these sectors and are coming with radical technologies and solutions. Healthcare, it's just beginning to happen. That after seeing all this happen, today, the Ubers, Airbnbs, Lyfts, all these big companies of the world, Facebooks of the world, if you look at it, Google has a health initiative going on. Amazon has one, Samsung has one, Facebook has one. So today, finally, we are seeing a lot of interesting activity in healthcare that we need to solve this very, very differently and with technology. And what is going to happen for sure is, at least the part of the world I come from, it will leapfrog. It will not work with trying to bring the legacy models or systems to more people. It is for sure people who have access to no physical health. I'm actually not surprised if 4 in 10 people have never seen a doctor. I presume it will be a higher number in India. And it will not be changing in the way we have been physically delivering healthcare. It will have to be digital highways are getting close to people much faster than physical infrastructure, and that's where a lot of technology is coming in. I think AI, machine learning at one level is changing the game. Telemedicine is connecting people like never before. E-commerce and e-delivery of a lot of healthcare information services is going to become more and more the norm, and that's what we are seeing.
But how have regulators viewed this? I mean, there's traditionally been, and as you said, there's a lot of legacy, and we as doctors like where we are in the health system. Today, healthcare is optimized around the doctors, so the three of us have a really good deal, but I suspect patients don't get such a good deal. So, and the moat is very deep. I mean, I was speaking to one of the IBM engineers who was saying radiologists will be out of a job. Then I asked, which engineer will go to jail if the algorithm is wrong? And he said, oh, no, we're just programmers. So the moat is deep and it's wide. And how do you see regulators starting to recognize the needs and perhaps take a bit more risk in regulation?
Yeah, no, I think it is a complex challenge for a lot of things. Regulation, by definition, is ensuring everything works in one set way. Innovation, by definition, is doing it completely different, and that where the two meet is always a process. And specifically in the case of India, I think for the last 2 or 3 years, there have been a lot of active conversation. Finally, there is a very clear recognition. I think now we are almost hitting a time of desperation, that we actually have to try new things. And it'll be very interesting to see how it plays out in different parts of the world. I think the regulators in India have taken a very proactive stance now that we have to try, because there is no other option right now. Why is it necessary is because at least that much is understood, that the old model is not working. Now, what kind of technology and what all is coming on board? Like, it does not have to be a replacement of the radiologist, but it can be significantly enhancing the productivity of a radiologist. If very fundamentally what a physician would do, there are a set of rules you learn in medical school. Those rules keep getting updated over a period of time. And then there's a very strong layer of pattern recognition that you add on top of it. And the doctor, that's why, gets better as they see more and more patients. A computer can certainly know and learn for sure all the rules and the new rules that are coming and old that are going, and can have access to so much more data than a human can. Can that be used in future for doing 80-90% of the triaging part for a doctor, that potentially these are the 5 areas that you could look at, and then so the doctor spends 10% of the time, becomes 90% more productive, because the current number of doctors will not be able to cater to the current number of consumers. And that's also productivity is the way to bring down costs. And that's how one needs to look at technology, not as that a doctor is redundant. In fact, doctor will become better when he leverages that technology. And that's what we've seen across every industry. It's rather than doing the same thing, like actually doctors have largely been doing the same thing since the beginning of the practice, is see patients and advise. And it works. It used to work for a large part of the population as well, but today we are realizing that a significant portion of the community is actually not getting that benefit.
Absolutely.
And that's the challenge right now.
Yeah, and one specific example that I would share is in retinal photography. And I think Google 2 years ago published a series of really papers where pattern recognition, the machine reads retinal photos to essentially recognize early stages of diabetes, eye disease, as good as the ophthalmologist. And in fact, because statistically about 80% of these images, they are normal anyway. So we don't even need the machine to be as good as the ophthalmologist. We just need the machine to recognize what's normal, and immediately productivity jumps 5-fold. So that's a very concrete example. What about in the world of surgery?
I think surgery brings us back to earth in some ways, reminding us that while innovation and technology has an enormous role to play in surgery, it's also got to come to the patient. We can't do everything digitally and remotely. At some point, when you have an obstructed labour, or you've been hit by a car, or you have an abdominal emergency, you actually need to have an operation. And you want to have that operation done safely. Right? So the question for us really is, how does technology and different ways of delivering healthcare, new ways of doing things, actually help us to ensure that more people around the world can get safe surgery when they need it? I've shown you some pictures about the infrastructure. That is a huge barrier. Even with training a few 100,000 more specialists, even with injection of funds into the system, nobody is going to get a safe operation if they don't have a safe environment in which it can be done. So I think this is a really high priority area. And when you look at these sorts of facilities, they're built into old hospitals. The rest of the hospital looks like this. And if you think, my goodness, that's a big challenge. Now we've got 350 hospitals in Myanmar we need to rebuild. Well, that's clearly not feasible in the short to medium term. And it's not necessary, because safe surgery needs a safe operating theatre environment. It doesn't need, 5-star hotel room beds. It doesn't need, 4-course dinners. Right? But it does need the place where the operation is done to be done well, and the equipment and suppliers to do it. So we've got a consortium that's working on a new model to do this. It builds on Singapore's focus on prefabricated, pre-finished volumetric construction. You know, the Crown Plaza Hotel extension was built at Changi Airport in 28 days by Dragages that built each hotel room off-site and then stacked them up like Lego blocks and connected them, and voila, five-star hotel. Right? Same principle has been in the HDB block apartments, and HDB recently announced this week that all future apartments are going to be done using the same method. We've taken the same principle to operating theatres. And can I just show you a little animation? Can we have the next slide up, please? Sir, can you put the slide up just at the end? So this is a little animation for this project, which is a partnership between universities, governments, including the government of Myanmar, and private industry. We're exploring how a model of building operating theatres off-site, up to world standards, fully equipping them, equipped with the latest technologies for infection control, for... scroll through, thanks. There's the fourth slide. So a world-class operating theatre environment can be deployed to a hospital in Myanmar and plugged in like a plug and play. Next slide. This should be the fourth one. There, this one here. It's a little animation. So click a box. It's an animation. Yeah. Nope, no, it's not. It's an animation that disappears.
Oh, the limitations of technology. Oh.
No, it doesn't work. No.
Thank God. So we still
Doesn't
have
matter.
jobs.
So the idea here is that you can build an operating theatre and plug it into the rest of the hospital, and voila, within a week you have functioning, safe surgery and anaesthesia that's got modern infection control, modern equipment, modern standards, and it becomes a training vehicle. It becomes a capacity building thing, not just providing clinical care to patients, but also teaching hospitals how to have high throughput.
And will it also be lower cost?
So it's certainly lower cost compared to rebuilding hospitals, but I think the interesting thing from a financing point of view is this opens up incredible new models. So the hospitals, rather than upfront investment in rebuilding their hospitals and procuring new equipment, these could be leased. They could actually have a leasing mechanism for high quality hospital equipment. Furthermore, it opens up markets for industry partners that don't currently have access to those markets, the big multinational corporations that provide surgical equipment.
Maybe can I ask a bit? Last week, Tony Fernandez, the AirAsia CEO, on a Hard Talk, famously said, when asked what would he like to do after AirAsia, he said, "I'd like to do low-cost hospitals." If I asked you to wear the investor hat, would you invest in low-cost hospitals, and why or why not?
Yeah, so let me keep the B capital hat aside and the investor hat aside. In fact, in my previous fund, coincidentally, I did invest in a low-cost hospital chain kind of in Asia. But even there, if you reflect back, what were they trying to solve for, right? They were trying to solve for, in parts of Asia, the better quality care are in the bigger cities, right? So the tier 1 cities have the better hospitals. And so when someone gets impacted with an emergency cardiology problem, oncology problem, they go from a smaller city, they travel 100 miles to the bigger city, right? So conceptually it should work where if you put up a hospital in the smaller city, people should kind of go there. The problem is doctors are not willing to go to the smaller city, right? So when you're saying, this is like someone jokingly said, doctors are kind of a very simple people. They just want kind of recognition, some recognition, working for the best hospital in a large city, and so
we are like investment bankers. We follow the money.
and so I think the biggest challenge for exactly that is medical professions, nurses, doctors are not willing to move to the smaller city, right? And so how do you solve that? Mindset change is going to take a while, but again, I come back to it. Technology can't be a complete disruptor, but it will be a very strong enabler in healthcare, right? So can you make a doctor in a larger city provide telemedicine services, or one of the leading oncologists in a big city provide telemedicine once a week? It's a solution which is now working across India, Indonesia, other markets, right? And so I think, even to the earlier question, I think the way healthcare tech will evolve will be very different from compared to consumer, auto, financial services. I think you need to work with the ecosystem. So the tech companies need to work with the regulator. They need to work with the providers. They need to work with the peers. And I think that's how you kind of create more impact. So I think that's kind of one of the propositions that have. You know, as a student, I had studied at Oxford, and so I had experienced NHS. And kind of, it took me a long while. I had a cold, I probably didn't get an appointment. And so, but I was pleased to note that even right now, they start to adopt digital health as a first level to can help triage, right? So whether it's things like primary care, but also things like mental health, you know, they often think digital is the first level of getting additional support. So I think, you know, to be fair, regulators, public service providers are getting smart about it. Depends on the country, they are getting progressive. So that's the good news. I would almost make the claim that, you know, healthcare is on the S curve. It's at the lower end of the S curve, but immense potential of where it can go. And I think that's our view, even at B Capital, saying let's catch it early on that S curve and be part of, you know, great teams that are trying to move up that S curve and have massive impact and transformation.
Thank you. And I'm going to open up because there are so many brilliant people in this audience. But let me start with people who have 2X chromosomes. Ladies. Yes, please. Over there. And do we have a roving microphone, or is the room small enough?
I can talk loud. I'm an academic. I'm from the Yale School of Public Health, and I'm here at Yale NUS for the year. So you might have a sense of what my question might be. I really appreciate the discourse so far, but I want to ask about primary prevention and sort of the balance between probably high touch and high tech, and how we might see that be, we would say meet the triple aim, right? Better care, improved outcomes, and lower cost. So primary prevention and the balance of tech and touch.
Anyone wants to start?
So I can give you an example from trauma, right? Where the greatest gains in the world have been around injury prevention. In the state of Victoria, it's got one of the most developed trauma systems in Australia. It peaked at declare war on 1034. 1,034 people died on the roads in Victoria in 1969. It then was the first jurisdiction to bring in seatbelt legislation. Then followed that with red light cameras, speed cameras, motorcycle helmets, etc., etc. And by 2000, the road toll was about 400. And then we've developed the system of care, which expedited emergency access to the sorts of services I was just talking about, and cut it right down to now to about 250 deaths on the road. But it's a systematic approach, and I don't think we can think about prevention in isolation from care, and we certainly shouldn't think about care in isolation from prevention.
I think maybe one example that would be worth looking at is how AIA, the insurer, is rolling out Vitality across the region. And I've been working with them for a while now. I'm struck by how many Hong Kong billionaires stop their cars 6,500 steps away from their office so that they can get a 20 Hong Kong dollar Starbucks voucher. So it's absolutely amazing how technology can allow us to track and also incentivize. And if you look at China with the ability of micropayments, I think we have only just begun. And maybe let me make a little pitch for my colleague over in Duke NUS, Eric Finkelstein, who's done some work in self-sustaining really incentive models. And let me just oversimplify. You enroll into a weight loss program, you pay some money. If you maintain the weight loss, you get your money back. If you lose a heck of a lot of weight, you get your money back and the money from those guys who didn't lose weight, right? So it's almost a kind of lottery or it is a gamble, but it then means that the impact on the public purse becomes very much smaller because the slackers are paying for the highly motivated persons. And I think if we talk about fintech, health tech, at least in the world of healthcare, we are really talking about behavior tech. And how do we change behavior using that blend of high touch as well as high tech? And maybe...
Yeah, no, so I think one, I just wanted to add to your point on incentives. One of the biggest problems in healthcare is misaligned incentives. The consumer, the provider, and the payer are optimizing for different things, and that kind of takes the costs really out of the equation. Now, and incentive programs are really important to solve. And you can make beautiful business models this way. Even I think a lot of pharma companies today are thinking of, for them, adherence is important. And if you can have an integrated disease management solution where if at the end of the year you are managing your disease better, say diabetes, and your HbA1c at 12 months is under control, then as a pharma company, you have a beautiful business because you have this asset you'll monetize way longer before that person goes into the next level of.
You keep them.
Yeah, so
you
it
keep
makes
them
sense.
alive. So
It
that
makes sense, and for the person, it makes sense. You're happy to pay for something that's making you better, fundamentally. But so a lot of these models have never existed because healthcare has worked on a single transaction basis for a lot of people. And the life cycle view is possible only with data and information and connected healthcare at all times. So now that is where the fundamental shift, I think, is going to happen over the next few years. The other point I wanted to make on just the prevention and also early response. What a big part of that is information access, just knowing what you should be doing and how you should be dealing with it. And one small example, we recently on our apps put a small, simple thing on how to deal with emergencies and snake bite, fire, stroke, whatever, different kinds of emergencies. And that's also where the point where the maximum can be done and the knowledge gap is the maximum. So what we saw was pretty amazing. We just put it out there and people are signing up, putting their entire health profile on it, sharing information voluntarily, and they want to know, just have this repository that tomorrow if I need it, I should have access. So those are the kind of things that are actually going to help.
Great. Maybe Bunsha, before we open to the next question.
Yeah, sure. So speaking about prevention, I think the tools, the tools are really there. You know, you can have screening and you have vaccinations. But the issue is how to get this to the ground, as in reach the mass population, educate them. You'd be surprised. You have mammograms, which are quite proven efficacy, but many people don't want to go for mammograms. Many women don't.
It's not very comfortable.
Not very comfortable, exactly. So, but then, eventually, if you reach the broader population, you will get a reduction in, and this is exactly what has been seen in the West. In fact, they are picking up of early cancers much better than in Singapore, actually, and that's a real issue.
So really, one of the challenges is that in the medical community know what the world should be doing, but we haven't figured out how to get the world to do what we think that they should do. Maybe can I ask for the next question, and maybe in the interest of time, can I combine it with Suzanne's question, please?
So I have two very short questions.
Please.
The first one is yesterday with Michael Milton, he talked about DNA and how he thought that through the science of DNA, advancements and modification of the genome could actually help us fight cancer before, it becomes massively
Okay.
the disease in the body. So with our oncologist colleague, could you give us your thoughts on that? The second one is more around removed areas we discussed and AI, which we talked about yesterday. How far are we, in your view, from a system where you could have a drone drop a robot that a junior healthcare specialist could then take, and for the robot to actually perform a pretty difficult surgery? I mean, is this 50 years ahead, or is this just 8 to 10 years ahead?
We used to call them residents, now we call them robots. But maybe Suzanne, can I add your question?
I'm Susan Roth from the Asian Development Bank. We work on innovations with governments, especially in the area of digital health infrastructure. So I have two questions for Kavya and Prashant, and that is, what do you think is necessary from the government side to really leverage these IT innovations in the digital health space?
Okay, and let's take, maybe Bunsha, can you take the first question on the role of technology, DNA in very, very early stage cancer, and then can I ask Russell to talk about the robot and the transmission, then we'll talk about the role of government.
Sure. So when the human genome was sequenced, there was a lot of hope that we would be picking out and being able to define the populations that will eventually get cancer because of mutations in the germline DNA. However, that hasn't panned out because this population of people who have germline mutations that predispose them to getting cancer, it makes up a very small minority of the people who actually get cancer. In fact, about 5 to 10% only. And they happen in very common, in families, they happen in certain patterns. So that hasn't really happened. But what has happened is that we now know, we understand when a person gets cancer, what actually happens in the cancer itself with regards to the genome. It keeps evolving. So with each successive treatment, the cancer actually learns, new clones are formed, new mutations happen, and we have to tackle them, and this is like a runaway house. So the best way to do it actually is to prevent, is to detect it early, remove it before these things, this genomic instability happens, and you have a runaway problem.
And maybe, can I just ask a quick clarifying question? You had mentioned that 5 to 10% of current cancers have a known genetic basis. And the other 90%, is it because there isn't one, or the science has not advanced enough for us to know?
It's most likely down to bad luck, essentially. And this was published by the Johns Hopkins group, Bert Vogelstein, and we agree with them. Basically, it's just bad luck.
Okay, and we'll talk about good luck. You're in a remote area, you're gonna die, and Russell to the rescue.
Well, so robots. For delivery and access, yes. For surgery, not yet, and quite a long time. The big difference is that robots are great for repetitive tasks where things are mostly the same and few adjustments to that need to be made currently. I mean, AI may change that and may change that reasonably quickly, but in surgery, everybody is different, okay? And there are many, many, many individual nuanced decisions made during the course of any procedure, even a simple skin excision, for which a robot is not ideally suited. So far, the evidence of robots in surgery shows that they're more expensive and they take longer to do most operations. So I think we're still a fair way from even when they could make the right decisions to having them as a core part replacing surgeons, thankfully. But this is a great field of innovation and there's lots of exciting stuff happening.
And maybe just a quick comment that there's a lot more to surgery than just what the surgeon does. I was in Africa last year in the week that Jim Kim launched Rwanda's drone-delivered blood transfusion service. So the ecosystem around what the surgeon does is still very, very amenable to really technological advancements. Maybe, gentlemen, the role of government?
Yeah, so let me take it as both role of government and how they should think about technology, right? So I think the role of government, the answer is it depends, by the country, the kind of system, etc. Right? So the answer would be very different for the US, the UK, parts of Asia. But I think what is, it is a given is that infrastructure across the world is, it's not meeting demand adequately, and so the whole role of how government can think about technology for efficiency is a no-brainer across the world, right? So how should the government think about at the primary care triaging? So there's several people who are kind of accessing primary care. Some of them may not have access. So how do you kind of provide access, whether it's things like telemedicine, etc.? Are there virtual tools that can help you triage, what should be in emergency care versus require the doctor visit after 15 days? So I think that government enabling that becomes quite important. I think in areas like, for secondary and tertiary care, it is around, whether it's investing on things that can help improve the facility, right? So if it's around, usage of AI, robotics, etc., at the most highest end, to the secondary and tertiary cares, how do you kind of have additional support for physicians using technology? So is it diagnostic toolkits? Is it kind of ways where information or interoperability of systems is getting better? So just the medical records getting better. So I think that enablement is a role government should play very strongly.
So yeah, the role of government, I think largely three areas I think a government can play a very active role. Number one is just making sure that there is alignment of interest across the ecosystem. The multiple entities are working, markets need to work in healthcare, and governments can play a role there. The other thing is, along with that comes data privacy and things things on that this should not spiral out of control either, because this data is very, very valuable. So the governments have a role in privacy and how to manage all of that. On the infrastructure level, I think setting up protocols for the various entities to interact, which is at one level for electronic medical records. If it's in different hospitals, how do they become interoperable? I think countries like India have a huge benefit that there's no legacy infrastructure. In the US, the challenge is that there are different silos in which different medical information lies, and they need to talk, and how do you build those platforms? I think government has a very important role there. And then lastly, I would say is encouraging and unleashing innovation in this space, whether it be, we have seen certain parts of the world where they create sandbox environments where different kinds of innovation can be tried, whether it be a faster response, one window kind of a clearance on new ideas, new technologies, new things. Because the problem that happens often in healthcare is by the time you get all your approvals and this and that and clinical trials and other tests, and it becomes one super expensive, and most startups neither have the time nor the patience to figure that out over the next 5, 6, 10 years. So that's where the government can actually play an important role, and at least a few governments around the world right now are. And to the quick question around when I see the drones coming and doing surgery, I think the phase one would probably be remote surgery being performed by surgeons. I see that as a realistic possibility, where a surgeon is wearing gloves in the US and surgery is happening in some part of India or Africa, and it's just those controls, sensors, motion, movement, all of that stuff might happen. It might happen pretty soon. And full, I think that's the scary part, where robots will certainly be more intelligent than humans pretty soon, but that's a much more scary situation, because healthcare would not be the only thing they'll be taking over.
Maybe can I ask Belinda, how much more time do we have?
We have about 10 minutes.
10 minutes.
Jeremy, I actually had a question for Buncha. I believe he spoke about framing the cancer drugs and new research that could lower the cost of cancer drugs. Can I ask Buncha if you could expand a little bit on that?
Right. So, yeah, early on I mentioned that the cost of treating cancer, which has now become a chronic disease, and its efficacy has increased, is getting more and more expensive. So when I started prescribing these drugs, these small molecule drugs, it costs about $3,000 to $4,000 per month per patient. But now it's reached $10,000 to $12,000 per month. So how do we reduce the cost? One possibility which we have been exploring is to use another drug to reduce the metabolism of this drug. So you don't break it down so quickly. You reduce the dosage that's required, and then you can actually reduce the cost for the per patient. Now, it may not happen, it may not matter to a first world country where you have third-party payers, but in Asia, where people pay out of pocket, this may make the drug more accessible to a wider population of people. So the clinical trials that will need to be done in this area, and our group is actively looking at it, and we've got protocols already in place, and we're writing it up, and we're hoping that we can get that funded to sort of move forward.
And I'll be very surprised if first world countries don't want to save money. I mean, rich people are rich because they're good at spending other people's money.
Absolutely.
Right? And okay, I think we have time for 2 more questions. Can I ask, yes, Vikas, please?
I just had a question. I mean, we all talk about the positive age demographics that we see all across Asia, and I think many of us regard that as both as a blessing as well as a bit of a burden. My question is, given these age demographics, given the young population, shouldn't the focus, instead of trying to figure out how to get $250,000 immunotherapy drugs to people in Asia, shouldn't the focus be more on education? I mean, for example, I just look with cancer. I think a lot of people in the room might not even know, but processed red meat is a type 1 carcinogen that the WHO has listed alongside cigarettes, right? So
Bacon.
How much of the innovation in healthcare that we need here in Asia comes back down to education, and as a comment earlier made, is about prevention from a very early age, informing people and thinking about their habits and dietary preferences and things like that.
So in the grand scheme of things, how important are expensive cancer therapies, cutting-edge therapies versus good old-fashioned education for really primary prevention and so on. Can I take one more question before I throw it back? Yes.
So when I look at the history of innovation in medicine, particularly in digital health,
Yes.
all the meaningful changes appear to have happened as a result of government intervention. Take everything from Indonesia, even the most primitive healthcare systems in Asia. One of the things they all have in common is a very strong oligopoly among the doctors, which tends to protect the doctors. So how do you think about digital health, and how do you think that's going to evolve absent major government intervention in this part of the world?
Okay. Can I take the primary prevention, the really prioritization question first? And any comments?
Yeah, so I think that it's no different from the smoking issue that we had many, many years ago when there was adequate evidence that smoking was a type 1 super carcinogen, and it became a political issue because people want to smoke. And it's a matter of how do you change people's perception of health? How do you make them more aware and take responsibility of their health? You will always have people selling the noodle that you're talking about, which cause cancer. You will never remove that because there are some people who cannot afford anything else. So I think that it's going to take a bit of political will, a lot of education to the public, to the general population, and for that to get to that point. And unfortunately, we spend a lot of money, you're right, to treat the people who get cancer with very expensive drugs when we could have put that into the early, prevention.
Okay, we are the traditional and failed medical community, and let's hear from the exciting guys on this side of the room.
I think to your question on do you focus more on the aging or the young, I'd say at some of the answers both. And the reason I say that, while you look at a lot of markets of Southeast Asia, China, India, it's still a young demographic, average age between 28 to 33, depending on which country you look at. The stat is the number of old age population that's coming into the world is actually the largest by numbers across India, China, Japan, and some of these markets, right? So ignoring that is not an option either. I think it is, so that means it just requires, a bit of both, actually a lot of both. And I think the good part is there are solutions, there are ecosystems that are working on kind of solving them. So that the education, prevention, better kind of tools to kind of manage and track, and there's a lot of industries around that. But equally, there are a lot that are focused on, the high-end specialties, oncology, cardiology, and how do you kind of help using technology and other forms to kind of improve that. So I think that's kind of my view on that.
Russell?
I was just going to build on that to say every country in the world has wrestled with the balance between inexpensive prevention, education, primary health care, and very expensive specialist care. And every one of them has come to the same conclusion that it can't be all one end or all the other. There needs to be a mix of two. What is exciting is that technology is opening up different ways of doing those bits. So we can get better products that help with education, with access to information, with decision support for consumers on their phones, with contacting and interaction with their primary care doctor or specialist doctor. I interact with patients by email, by text message, by WhatsApp, and so they get better access to me. So there are different ways that technology is opening up that question and changing that balance, but we're not going to ever go all primary care prevention or all specialist care.
And maybe let me end off with asking the panel to address Cole's question on how do you break the medical cartel? Right. And maybe can I ask Prashant to share, because you had mentioned that the doctor of the future is the doctor enabled by technology. And do you think that the doctor enabled by technology will be so much more successful than all other types of doctors, that this will create that really social revolution within medicine?
So I think so. I think a more enabled doctor will be a better doctor, will be a more productive doctor, will see
Richer?
more patients. I'm
Richer.
pretty sure.
Richer.
Richer as a
On
result.
man, yes.
Of course, if you're seeing 10 times more patients, it's just economically the right thing to do, and you'll be spending time on more value-added stuff as a trained physician. So I actually think that will certainly happen. I just, to the question on how do you break the cartel, I believe it's one, changing the way the service industry has been working, bringing productivity in is critical. Number two that is critical is being aware that the patients are more aware now. And I'll give a very quick example. What we did with our app essentially was brought transparency in the prices of medicines, especially off-patent drugs in India. For the same salt, you have brands that are 70, 80, 90% different in prices. And we just informed the consumer that this difference exists. So just ask your doctor if you can move to a cheaper drug with exactly the same salt, and if the doctor will be okay with that. One, our app went viral, everybody shared it, that this is a great service. But the two part, that is, we did a survey of our consumers. More than 40% went back to their doctor and asked if I could take the same medicine from, instead of brand A, brand B, and save 70, 80%, is there a problem? And in the majority of the cases, the doctors actually said, if you can find that brand, no problem. So a lot of it is people start demanding this transparency, and there will have to be a response. So that's, I think, power of information will be critical, and it is increasing with certainly platform like ours.
So if I can sum up, we are on the cusp of a profound revolution that's unprecedented. Clearly formidable barriers exist, more on this side of the room. But I think that societies are demanding this, technologies enabling this, and I think politically we are starting to see that universal coverage is no longer just a buzzword or really lip service, but it's heartfelt. Right? And I think it's a very exciting time, and thank you to everyone for all the contributions and the comments. Can I ask you to thank our 4 esteemed panelists who have contributed so much? Thank you.